Feeling a little bit discombobulated. So my name is Dan Grasser. I'm a hospitalist at Evergreen in Kirkland. I also did my residency at the University of Washington. I graduated in 2011 and went after residency to Evergreen. So I've been here for 10 years now. I took over as the medical director of our group about a year ago. Have been enjoying that experience, which has moved me to more of an administrative role than a straight clinical role. And very happy to be here and happy to answer any questions that you have.
Thanks so much. Dr. Goulet.
Hey, good afternoon, everybody. I'm Delaney Goulet. I was a graduate of the UW Med School and then went back east for residency at Brown and then stayed on faculty there for a couple of years. And I'm representing the Everett Clinic today. We are the group of hospitalists that work up at Providence Everett in the medical center. And we run almost all the inpatient beds there. So we are also starting the Washington State University internal medicine residency this year. So we are bringing more academia to Everett, and I'm very excited to answer questions on the hospitalist or residency side. But I've been there for 3 years as a hospitalist. I'm part of our steering committee, which is like our team leadership, and then also an associate program director for the residency. So very excited to be here today and talk to you all.
Great, thanks. Dr. Babcock.
Hello, everyone. I'm a graduate of UW Internal Medicine residency. Actually, Dr. Grasser was my co-resident. And I was actually the outpatient chief at Harborview in 2012. Jen Best was one of my teachers as well. It's great to be back here and in the UW system. It's a lot of fun. I joined Swedish in 2012. I actually worked as a nocturnist for about 4 years. And then I took over managing the scheduling and sort of staffing in 2016, and then became the first chief hospitalist in 2019. Swedish has 5 hospitals, sort of different size, and there's a chief hospitalist at each of them. And then above each is our executive medical director, who is Naomi Diggs. She is in school getting her MBA, and so she wasn't able to attend today and asked me to do so in her stead. So
We're glad you're here. So those of you who are on the resident side, clearly you're seeing that there's a theme. We have a lot of our grads in a lot of different groups, obviously across our community and our region. I will say that the 2 groups that plan to be here today that were not represented because of clinical catastrophes, it sounds like, are Dr. Kajuria from Virginia Mason and Overlake. Jamie Boswell from Overlake was planning to be here as well. So they're also kind of following with interest, and we'll get their information out to you soon. Any other panelists? No, I think that's just the 4 of you. I'm so glad you're here. So what I would like to start with is maybe kind of a context setting question that I'll open to the whole panel. And that is really kind of curious. I know residents have a lot of interest in the hiring market and the impact of the pandemic locally, kind of in the Seattle area and beyond, and how that might be changing what your groups are doing, changing how residents should be thinking about looking for positions, if at all. Just would welcome any perspective as kind of setting some landscape for the rest of the questions today.
You go ahead, Dan. We're all like, wait.
who's going first?
So, I think our general experience over time is that we have had been looking to hire 1 or 2 hospitalists per year at least. I think we've actually had less turnover this year than we normally would anticipate. I think just everything was more uncertain, so I think people just were putting a pause on any career changes. I think that also occurs within the broader financial realities of a post-COVID recovery year. I think most, if not all, of the healthcare systems are experiencing a little bit of tightening of their bottom line because of COVID. So I think that my sense is that, at least for our group, hiring is a little bit tighter, but that we would likely be looking to hire 1 or 2 providers for next year.
Great, thanks. Carolyn?
Yeah, I was going to say, and it might just be because, you know, we're UW Medicine, we've always run a little lean. Actually, with the pandemic, we found that hospitalists were incredibly crucial and important, as you guys also saw with the how the hospitalists at all the campuses kind of took care of a lot of the COVID patients. And so, at least at Montlake, we've actually gotten a service expansion this year because we realized that, man, we need more hospitalists, right? And I think we'll continue to see that. So I think at all the campuses, we can expect there to be availability next year for sure.
Great. Ethan, you're off mute.
Yeah. So I would say that as R2s, you're actually in a better position than this year's R3s because there has been so much uncertainty. Speaking for Swedish in particular, we're just starting to sort of come out of the COVID era, and it's still sort of uncertain what our true numbers and true needs are going to be. And I think by the fall, we'll have a much better picture of where we're going to be. We're a large group, and staffing is fluid. So I'd say probably similar to Evergreen, we'd be probably looking to hire 1 or 2 grads the following year. You guys should know that coming from the UW, you are all excellent candidates. And I would just, the other thing I would point out is that staffing is fluid. And so you might get some sort of hesitancy like on 1 week, but then 2 or 3 weeks later, we might be like, oh, hey, situation has changed. We're really interested. So be open and flexible and know that things can change at a moment's notice. So.
Yeah, I guess if the pandemic has taught us one thing, it's to be nimble and patient, I suppose also, right? I just have one more question for all the panelists, and then I'm going to turn it over to the residents here. But I guess I'm wondering if each of you could just speak a bit to the size of your program, the services that you cover, and basically kind of like maybe an average daily census.
I'll start.
Sure.
I missed the last question. So
I'm sorry, please.
That's
Yes,
okay,
go
no
ahead.
worries. So I was just going to mention that, you know, we were able to kind of have people drop some FTE by choice during the pandemic. So we actually got really lucky and haven't had to make any changes because of the pandemic. And now actually for the last month, our hospital's been full. So we're a group of about 70 hospitalists in Everett that serve Providence Everett Medical Center. And we usually hire between 3 and 8 hospitalists a year, and that's certainly been true every year I've been here for the last 3 years. I think we're bringing on 5 this year. So the other thing I would say about our group with 70 hospitalists, we have a lot of flexibility in what FTE people want to work. So we serve a 600-bed hospital as a group. We are the primary team for most of our services. So if you're surgical, you're obviously not on ours as primary, but we consult for all the ortho, geriatric, fracture teams. And then other than that, we take care of all of our neurology patients as primary, our hem-onc patients, and our renal patients. So it's actually a really nice mix. We also have a closed ICU, but we don't have a step-down unit. So I regularly manage people on high-flow oxygen and sometimes drips for, you know, AFib, or sometimes even hypotension or heart failure. But I guess, so 70 hospitalists and lots of flexibility in FTE, and we plan on hiring quite a few people the next few years. I think that answers both your questions, Jennifer.
Just brilliantly, thank you. Who's next? Ethan, you're smiling.
Yeah, I can't see the other panelists, so it's hard to know, hard to read their body language. Because I work in teams primarily as well and less familiar with Zoom. So our group, is about 100, 110 providers. We have hospitalists, MDs, and we also have APCs or APPs, depending on your terminology, ARNPs and PAs. Our rounders carry about 15 to 16 patients a day on average. And we have a closed ICU for the most part. Particularly, well, it's closed during the day. There's a couple of locations that are open at night at the moment. But we do have a step down unit. So basically you have to be intubated or on a pressor to make it into our ICUs. So we deal with some pretty sick people, and we're the ones who identify them on the floor and have to stabilize them before the ICU gets involved. We're a little bit different in that we have 5 hospital locations. So we have Edmonds Hospital, which is up north, and then we have Issaquah, which is out east. But our hospitalists they don't tend to stay at one hospital. They tend to rotate. So people either work sort of in a north-south corridor or an east-west corridor. It kind of depends on where they live and where the needs are. We are the primary service for most of the inpatients in our system. I think we are about 1,000-bed hospital, and if our census up across all the campuses, it's around 350 to 400 patients. So,
thanks, Dan.
So Evergreen is a community hospital, single location. It's actually one of the state hospital districts. It's Hospital District 2. And our group is 44 MDs and 3 nurse practitioners. We at any time have 10 rounders who are carrying generally 14 or 15 patients with the census capped at 17. I think in contrast to Everett in Swedish, we do have an open ICU where we are the primary attending for most of the medical critical care patients. And obviously we have a robust pulmonary critical care service, but overnight our nocturnists are the docs who are in the house. There isn't a critical care doc who is in the house necessarily. We have a pretty broad spectrum of patients that we see. Obviously bread and butter medicine. We admit a lot of the cardiology patients, but there is a primary cardiology service. And also there is a primary oncology service. So we end up consulting for the oncology team pretty frequently. I think those are sort of the major details.
Yeah, census. Did I miss that? I'm sorry.
Oh, yeah. So generally 14 or 15 patients today. We cap out at 17 encounters today, and then beyond that, we call on extra help for risk. Very
good. Thanks. And Carolyn.
Great. I'm going to try to cover everyone. So talking about Montlake first, because that's my campus. So our folks kind of cover 3 major services: hospital medicine, daytime, consult medicine, and nights. Most people coming in will do 2 out of the 3 of those services in some combination that makes sense for the individual. So it might be majority days, part nights, half consults days, or for some people, they really like to do nights and do a majority of nights. Our group is about 25 FTE with 33 providers, and our census is the same as kind of the regular resident census at 10 per service. Harborview, Jen, you might be able to talk to a little bit more too. I haven't heard back from Kim, but I think they're a little bit bigger, maybe a few more FTE covering day medicine, night medicine, consults in co-management, and also an opportunity in pre-op clinic. And and I know that they're probably going to have some room for FTE next year. And the service is capped at what, 12? Is that right, Jen?
You know, I'm just on the teaching services now, so I don't actually know. I think that it was 12 last time I was on hospital medicine only services.
I
Yeah.
want to say it's 12.
Yeah.
I want to say
That seems right to me too, but. Yeah.
Last their group is 29 FTE. They anticipate hiring 1 to 2 FTE next year, and the daily census there is about 15. And then the VA, there are 29 folks in their group, and the average census there is 8 or so, also covering 1 to 2 primary consult patients. I'm going into less detail than our other folks because I know you guys know our system a little bit more and want to make sure you get a well-rounded.
Yeah, that's great. That's just a kind of a broad survey. And now actually I have questions that are starting to come in through the panel. So let's start with this one. I guess the initial question is, do you typically hire folks for a specific service line, or do you if like a co-management service versus acute medicine, or do people generally rotate through a series of types of clinical services? Or does it differ based on site?
I can start with Everett. So we only have day docs and night docs. As a day doc, you take consults on your team just as part of your regular service. So it's a mix of consults. But the day docs don't tend to have to do any night shifts. At most, you might get one in a whole year. And the night docs do some swings, but no day shifts. But we don't break up the service like the consults versus primary team like that.
Okay. Other models?
We at Evergreen are pretty similar. We do have a dedicated team of 6 nocturnists, and the day doc can expect, every 3 or 4 years to have to cover a week of nights. But generally, if you come on board as a day doc, you'll be working as during the days and covering just the sort of general medical service.
Anybody else do anything differently?
Yeah, so at the U, so Northwest, I think everybody who comes in does both days and nights, some proportion of nights. At Harborview and at the U, similarly, I think most people will do at Harborview, most people will do a proportion of days and nights, but that FTE is kind of malleable depending again on the candidate and what the need is. At Montlake, it is a little bit different because we do have this consult service, which is a little bit separate. So when we do hire, we'll hire with that split FTE. So you might be 60% consults and then 40% days. But on all of our services, you are rotating through a variety of services. So you might be rotating on the hospitalist only service or on the oncology service or on the teaching service, for example. And those proportions are kind of split evenly amongst our group.
Okay, great.
Yeah, ours is similar to Everett and Evergreen. You're basically a day doc or a night doc, and you do some swing shifts. There is we have a dedicated triage doc at each one of our hospitals. That's sort of a self-selected group of people who are willing to do that work because it requires a high level of communication and multitasking skill. We do have a small teaching service. That's one service line at First Hill, which is again sort of a self-selected group of people who are interested in teaching. We're teaching, it's a hospitalist fellowship for family medicine grads, and there's about 3 every year. So.
Okay, great. I feel like we're going to just start plowing into questions here now, so I apologize if they come real fast. But there was some curiosity around the relationships working with APPs. And whether that working relationship is, again, service dependent. And if you are working with APPs, what are the responsibilities of the APPs? Are they doing documentation? Are they managing pages? How is that work delineated?
Up in Everett, we have nurse practitioner teams. We have 3 to 4 MP teams on at all times. And they actually do all the procedures unless you're a doc who wants to do your own procedures, and then you're very welcome to if you have privileges. So they carry their own 12 patients a day. We dole out patients to them just like we do all the other teams every day. but we don't like have to manage them. If you're on the leadership team, the steering team, they do come to you with questions, and that's like a really fun part of working with them.
Great, thank you.
Our model is similar. Our APPs carry about 12 patients. There's a couple service lines at each of our sites, and then we treat them pretty much just like our hospitalists. They get their patients, they see them, they take care of them. They're required to get a co-signature on for hospital bylaws on their admissions and discharges. But we select highly trained ones who can work to the height of their license and be as independent as possible. And so the MD's responsibility is just to be available for questions, and usually the supervision is split between a couple MDs, so they'll supervise maybe like 6 patients. And we have some APPs who've been working with our group for over 10 years. And it's basically, do you have any questions? No. All right, good. Move on. We do have some younger grads, and so they'll have some more questions, but again, it's a really collegial working relationship. So it's great.
Yeah, it sounds like you're selecting for independence, and so supervising is not a high proportion of the job, if that's fair. There's another kind of large bucket question here, which is kind of thinking about how a lot of folks apply for these jobs, right? And the number of positions vary from year to year, but how do you distinguish between candidates? Like, what are you looking for? How do you make those calls when you have more people than you have spots?
I think at Evergreen, one thing that we really look for is someone we think will fit with our culture. And I think in some ways, the UW grads have a leg up because a large percentage of our providers are from the UW, and so they have a similar practice pattern. And so I think that is definitely something we look for. And then I think we're really looking for providers who are interested in critical care and feel comfortable with that. And so I think those are the major characteristics we look for.
Thanks.
Yeah, up here in Everett, I would say culture fit is number one. But with that, with 70 folks in our group, there's quite a spectrum. I find that most people coming in find a niche of providers they, really like to have lunch with or whatever. But there's like 25 of us there every day, and in general, everybody gets along. So culture fit's number one, and we've been really big on trying to get people to visit even during COVID for interviews because that's such a big part of our team. We all enjoy being together. The second thing, though, is we're looking for people who want to help make the system better. So people with experiences where they've participated in QI or been a part of committees, and chiefs. Obviously, we've hired quite a few chiefs in the last few years, people who are bringing in some interest in other activities. I will just throw in that on top of the salary and any quality bonuses or performance bonuses, there's also project hours set aside up here where you get 50 a year to participate in things that will benefit the team or the hospital or the system. So it is like paid extracurricular time to be making the environment better and making the system better for where you work. So that's been a really nice part of being a part of this group.
Thanks.
Yeah, I think at UW Medicine, of course, culture and fit is important. And, again, being graduates, you guys know what our culture and our fit are. But other things that we look at, specific domains that we consider are, clinical acumen, communication skills, diversity, scholarship potential, and teaching skill. Because, being the academic kind of representative here, we want to make sure that that's really important to the folks who are coming through.
Yeah, I'll echo what people have said before, which is that culture is really the most important thing for us. And our founding provider actually created a cultural document that we share with our interviewees and say, hey, does this match with your values and whatnot? It's like 10 things. And then the other thing that we look for, and that we as a leadership group, we're all highly engaged individuals. And so if you are a similarly engaged person looking to make the system better and interested in that stuff, that also resonates with us. And then I'll echo what other people have said, which is that, I trained at the UW, Naomi Diggs trained at the UW, so we know what your training is like, so you guys definitely have a leg up in that situation.
Awesome. I'm going to move now to just a question about folks who anticipate that they may pursue fellowship training, but might be looking to do hospital medicine for a while before they apply to fellowship. I think the question is kind of how should applicants who know that that's part of their future or likely to be part of their future approach that with hiring groups? Should it be disclosed? Does disclosing it disadvantage applicants at your groups? Some perspectives on that.
I think that's a good question. We certainly have a contract that requires a 2-year commitment. So that is certainly what we're looking for, because I think everybody understands there's a ramp up period getting used to a system. And if you're coming straight out of training, there's a ramp up period getting used to carrying out a certain number of patients. But with that, we have had people leave either before or after 2 years for fellowship, and for the most part, everybody's supportive and we haven't had any trouble filling those spots. So I think it's just a matter of which year it is and what we're looking for. It's always worth a try.
Yeah, I think that's true. I think it partly depends on the year, but it also is, if that's what you're interested in. I mean, I think hospital medicine, being upfront and honest about that is always helpful. Also to make sure that you're finding the right fit for you, depending on what it is you're trying to accomplish with your hospital medicine years before going to fellowship, right? Is it that you just want to get reps, that you want to, make sure you kind of consolidate some of your knowledge, et cetera? And I think being clear about that for yourselves as well as with the people you're interviewing with can only really help. But we've definitely hired folks in the past who we knew were probably going to only stay for a year or two, with the plan of going to residency, to fellowship, and finding the right experience at a place like Montlake where we can shift FTE in certain ways has been helpful. Oftentimes those folks want to do more nights, right? Because it gives you more flexibility, more opportunity to work on research products, et cetera. And it can often be a mutually beneficial arrangement.
Yeah.
Ethan?
I would agree with a lot of what was said. I think at Evergreen, we are looking for people who are interested in a career in hospital medicine, and in particular, looking to sort of set up a career at Evergreen. And to be honest, a lot of people do end up doing that once they've started working here. I think that being said, things change, your career goals change as you become more familiar with the realities of being a hospitalist. So I think just trying to be as honest as possible about sort of what your career goals are and what you sort of see yourself doing in the future will help you come off as authentic and probably help your interviewing process.
Yeah, I'd echo what people have said, being open and honest, and also saying like, I'm not sure, I think I might want to do this, I might not, is totally fine. And in fact, some people have sort of started thinking they wanted to go down the fellowship route, and then they find out that they just really enjoy hospital medicine and want to stay at that. I don't know how the other institutions handle this, but at Swedish, we also have a fair number of sort of moonlighting contracts where people can pick up open shifts and sort of work sort of in that way. And we have some people who've actually left for fellowship, but stayed on as a moonlighter and picked up like open shifts, swings or nights or, whatever. So that's another possibility.
Yeah, great. Thank you for that. There's kind of another bucket that we'll go to now, which you kind of saw coming, and most people don't always want to be the one to ask that question, but can we just talk rough salary? I know that the salary structures and the ways people are paid are really different and complex, but like if you could just like give us a ballpark, given that these are folks that have been, muddling through training and are looking forward to having a good salary. So that's one question, kind of rough salary range. And then I'd be curious if any of your groups, or if you know of any other groups in the area that offer public service loan forgiveness.
Sure. So up at Prov Everett, we do not unfortunately offer public loan forgiveness that I know about. The Everett Clinic is a for-profit company, but I get to work at Prov, which is great because it is not for profit. And so I serve a lot of the same patients as, say, Harborview in Seattle. Then in terms of salary, I've been shocked coming from academia, but we are around 300 plus productivity and bonuses for full-time, and full-time is about, I think it's 2,020 hours your first year. And after year 2, you go down in your hour requirements for the year. It ends up being about 14, 12-hour shifts a month. Again, between 2 and 3 of those shifts are swings. The rest are long team shifts, which are 12 hours. We're half productivity and half hourly. So if you're a higher RVU person, you will get more than that. And then we have citizenship bonuses and quality bonuses as well, which is like filling out all your team surveys and rating your peers and doing a good job as a physician.
So at Evergreen, full-time FTE would be expected to work 21 weeks a year. Most people who are full-time work week on, week off, and then each quarter you get a week of vacation, so that ends up being basically a 3-week block that you're off. And our salary at this point is all, or sorry, our compensation is all salaries. We have a small amount that's a bonus based on productivity, and sort of our salary is in that same range, just around 300,000.
I'll go next. Yeah, our salary range is around 320,000. We work full-time day FTE works 172 shifts a year with 7 days of vacation. It sort of basically comes out to about similar to Evergreen, sort of 22 weeks a year. Our nocturnists work 1 week on, 2 weeks off, and have like 5 extra shifts a year. Our pay structure, 80% is our base. 80% of that number is our base, and 20% is a sort of quality bonus. And our group has never missed their group metrics, not individual metrics, and our group has never actually missed our quality bonus. So
cool. Carolyn?
Academic institutions are a little lower. I'm sorry, I can't speak to the Northwest salary. I know they're a little bit higher, but Harborview, the VA, and Montlake all are like around 200 to or 220, depending on your kind of proportion of days and nights. You do get paid a little bit more for night work. And then at Harborview and at Montlake, it's 168 days per year per FTE. And again, I'm sorry, I don't have the Northwest numbers, but I know it's a little bit higher. I think they're in the 230 to 250 range, but I don't quote me on that.
The one thing I'll say about UW that often doesn't kind of sell itself, obviously on paper, is a ridiculously awesome retirement and voluntary investment plan that actually offsets, like over time, it adds quite a bit to savings. And so I'll just add that as somebody who has chosen the lower paid route throughout my life. They have really good benefits. All right, so that's helpful. A number of you, I think all of you, I know that all of you have teaching opportunities at your site, some with students, some with residents, fellows, and others like nurses. Maybe if each of you could just talk a bit to kind of the teaching services that you have available that folks may be part of if they choose to come. And we'll start with Carolyn.
Well, I think you guys know a lot of the teaching services that are available. So at Harborview and at Montlake and the VA, obviously there's the time that you have on the resident teaching service. On top of that, I know that there are sub-Is, I think, across all campuses. And I think that that just represents another teaching opportunity. And then of course, there are the residents on at nights at all of the campuses. Up at Northwest, I know that there's a medical student track that you can choose to be a part of. And if you do choose to be a part of that, then your clinical expectations actually a little bit lower. So instead of having you cap at 15, I think the cap is lowered a little bit for that particular track. But then beyond, of course, the formalized teaching opportunities are all of the opportunities to get involved with the medical school, get involved with residency, do noon conferences. And those are kind of countless, and it really just depends on the individual and what you're looking for, because all of the opportunities are right there at your fingertips.
Delaney, for you, a specific question about how the teaching services are structured.
Yeah, so we have had learners up at Prof Everett for a long time. So we've had UW students since I was there. That's actually how I got recruited back. And we also have had Washington State University students over the last 4 years, but now we're starting the Washington State residency. So we actually have 3 of our 18 or so day teams are going to be teaching services with residents and students. So our UW students will now fall onto one of those 3 teaching services. So after this first intern year of residence, it will be like a standard teaching service with a senior resident, 2 interns, and then 2 students will be taking sub-Is. And you can opt in to be on the teaching services. We have a big group of our hospitalists who don't want to be involved in teaching, and that's totally fine. And then for those of us who do, people are doing between 2 and 6 months a year. And when you're on the teaching service, you can split up the days as you want with your colleague on that service with you over a month. So we don't demand like 1 week on, 1 week off. That's the same for all of our providers, by the way. You can choose if you want to be on a set template or not. Otherwise, you'll just get kind of random groupings of 4 to 7 days in a row. So that is inpatient. You'll have a chance to work with, both students and residents. And then actually, we're also starting the resident outpatient clinic. And so some of our hospitals have decided they want to do some post-discharge follow-up in that clinic. So that's the other opportunity.
Great, we'll go to Ethan next.
Yeah, so I mentioned our hospital fellowship program. The physician on that service actually carries a lower census of around 12. So they can supervise the fellow. It's just 1 fellow on at a time. And they carry a census of, 8 to 12 themselves. There's UW R2s and R3s who rotate through, choose Swedish as an elective. And so they also rotate through on that same service. And then we have a partnership with WSU as well, with some med students and I think sub-Is who come through. And those, I think there's more of those students up at our Edmonds location, though a few come downtown. So.
And Dan.
And then, so we have med students from UW about 4.5 months per year. And there's a dedicated teaching attending for that time frame. That doc carries a lower census, again, similar to Swedish of 12 patients. It's voluntary. You can teach if you want to. If you don't, it's not required. If you're interested in just dipping your toe in and giving some lectures to the med students, there's ample opportunities for that also. And then we also do provide some education to nurses. There's a nursing residency program up here that will provide some educational lectures too.
Great. Yeah, one of the, oh, go ahead, please.
From Northwest, I just want to make sure that the salary,
yeah,
it's $280,000 up at Northwest.
Okay, good to know. So we are at 2:22, so we're doing good for time. Y'all doing all right? Just coming at you. So let's talk a bit about kind of the mechanics of hiring. And there are some questions about when folks should start thinking about getting in touch. When should they be applying? How early does your hiring machinery start kind of on a typical cycle? Dan, we'll start with you.
So, I think sooner is always better in terms of just getting your name in front of the people who are looking to do the hiring. I think probably starting in the mid-fall time frame. If you I know what I did personally, what I've seen here is you send out a resume, you'll probably have an informational interview, and then probably come for an in-person interview. And then I think through the sort of turn of the calendar year, generally at that point, groups start to have a better sense of what their needs will be for the next year and start to look to hire, particularly for the new residents, for the residents coming out of the UW and other programs.
Ethan?
Yeah, I would say mid to late fall is a good time. And our process is similar, informational interview and then a sort of in-person or Zoom interview these days. We're not sure what's going to happen 6 months from now. Something to be aware of is that the sort of credentialing and onboarding process itself, after you receive like a contract, can take for around 4 months. So there's a lot of other, it's not quick. And so yeah, even if you applied in like May or whatnot, you wouldn't be able to start work until August or September. So just be aware of that fact.
Okay. Any other timelines represented here?
So the UW Medicine campuses all kind of do a group application process where we all kind of, you apply once and then you interview with all places, but we do kind of coordinate our offers so that you're getting normally one offer from one of the system hospitals. We normally start our process in August to the beginning of September. And just depending on how much FTE is open, sometimes we're putting out offers by the end of October. And sometimes, because again, it's kind of tagged to the academic year and the academic budgeting cycle. Sometimes we'll get service expansions late into January. And so all of a sudden have openings. That's what happened this year later in the season. But in a typical year, most offers are normally out by January. Anticipating a kind of July or August start.
Yeah, and up in Everett, I would agree with what everybody said. You know, the earlier the better if you know you want a job right away. Sometimes we fill up fast. And then the other thing I would say is that if in that initial, outreach, you're told maybe we filled up already, I would say don't stop asking. And I'll throw the physician recruiter's email in the chat for everyone. I have found personally, from my own experience as well, going through Lisa Chu, who's our main physician kind of recruiter, is a little bit more streamlined than going through the recruiters themselves. And that way you can stay in the loop if you are off cycle and you're looking for an opening, because they definitely happen.
Great. Can I go back to public service loan forgiveness? Because I don't know that we got answers from everybody and that was on me. So anybody offer that?
All the UW Medicine campuses are eligible for public loan forgiveness.
Okay.
Like it'll count towards your years, including.
Okay.
Swedish, to my knowledge, does not offer that. So.
Okay. Evergreen?
Similar situation at Evergreen. I don't think our providers are eligible.
Okay, thank you. All right, so feel free to keep adding questions in the chat. I think one thing that I guess because you have all been through this process and admittedly it's been a variable number of years since you trained, but thinking about this group here today, like what do you wish you had known when embarking on the process that you might impart as wisdom as they look to get this started? Delaney, you want to start?
I think I would just give you the confidence to know that like you're kind of in the driver's seat. It's the first time in your career where like this is up to you. Figure out what you want, what makes sense for your life. It may mean that you don't get the first job you apply for. It may mean you go to a different location, but like make sure what you're signing up for makes sense for you. Either look for a niche you want to try out or stick to a location, but there should be something in it for you. Don't feel pressured to sign a contract just because it's there and it's more money than you're making now. That's going to be true no matter where you sign. So you're bringing value. You're all coming from an amazing program. Make sure that you're getting something out of it for you.
Yeah, and I would say like similarly, yes, you guys are wonderfully trained. You're going to be highly competitive across the entire system, but don't put too much pressure on it either. Like, yes, it's a job, it's your first job, but things can change, right? You can decide after a year or two, like maybe this is the place, or maybe this isn't the place, or maybe I want to do some other mix of work. Again, like because we have this unique system at Montlake, there have been people who have started off as 100% nights and who are now like 100% days, or people who decide later on like they want to try consults, and all of that is possible. So don't feel like you have to have the perfect job, because your interests will change as you kind of move into professional life, and the opportunities will be there for you to adjust as well.
Well said.
I think I would say, reflecting back to when I was in R2, I think I was still intending to go into fellowship through all of R2 year. And then by R3 year, I knew I wanted to be a hospitalist. And I was convinced I was going to be at a UW site. And then I heard about Evergreen from one of the co-residents, and it sounded right. So I think keeping an open mind is important, and the process, you'll, I think, sort of learn about different locations, and where you end up may surprise you.
Yeah, I'd echo what everyone else has said. I actually trained, I was in the primary care track at UW. And I was like, well, I'll do the hospitalist gig for a couple of years, so I'll figure out my next step. And here I am 10 years later, still doing hospitalist work, but also doing a lot of administrative stuff too. I'm actually only 40% clinical at this point. And realize that, life changes as well, right? People have kids, or their spouse gets a great job somewhere else. And so sometimes something might not seem like the perfect fit when you start out, but a couple months down the line, something changes, a new opportunity presents itself, and you're able to sort of move in a different direction. The people in our group change FTE every once in a while, go down to sort of 0.75, or sort of come back up, or switch to nights, or switch from nights to days. So you're not locked in. It's really sort of up to you what you think is going to be best for you initially, and that the only constant is that there will be change.
Spoken like a sage. Is there anything else on this one? Now you guys have lots of questions, so this is awesome. So I think just some quick bits of advice around navigating multiple offers. And this is something we offer a Life After Residency and Fellowship seminar as well in the fall of next year, where we talk about contract negotiation and those sorts of things. But any advice if people are kind of trying to navigate multiple offers, and is it okay to tell a site that you're still investigating, or to ask for an extension of time before which you have to answer? Because I think people are worried they'll be pressured.
Yeah. Oh, go ahead.
Go ahead, Delaney.
I was just going to say, I mean, we tend to know like that our folks who are looking at us are probably looking at a lot of groups in the area. And again, we agree that like, we want you to find the right match for you. We don't want people to match here and start work and then a year later decide it doesn't fit their personality. So we actually want people to look around, and it's usually just a word of mouth, like saying, yep, I have a few more places to look at, so that we don't officially extend the offer until you think you're in that like 2-week window of knowing kind of what you're going to do. Because you don't want the offer to put pressure on you making a decision within 2 weeks if you know you're going to be interviewing somewhere else 3 weeks away. So I guess the honesty of like, I'll let you know when I'm about ready to make a decision is better, because then you'll get your official offer, which always has kind of a deadline on it.
I was just going to say that my own personal experience is that if you are really interested in going to practice, being honest with that group and telling them what the reality of your situation is. And in my case, I had a time limited offer from the UW, and so I needed to know faster than their normal timeline. And I just ask them to give me a thumbs up or thumbs down. And so I think just being open and honest and asking for what you want is probably the best way to go.
Yeah, I guess I would say, I think that's always the question, like, oh, is it going to hurt my chances at one place if I tell them I'm like interviewing somewhere else? Honestly, probably not, because it just means that you're a highly sought after candidate. And if anything, it's going to make people want to like extend offers quicker or whatever, right? Like they'll want us to kind of, I wouldn't worry about that. I think, again, like same with the fellowship, being honest with what you're looking for, being honest with what would make a